like to read the first question from Tony De Marcaida for Leo. It's a bit long, but it is about the graph that you showed early in your lecture comparing how hazardous healthcare is compared to other industries. The question reads, the introductory graph showing how hazardous healthcare is shows number of lives lost. I muted myself. Shows the number of lives lost on the y-axis and total encounters per time on the x-axis. Does the graph actually reflect deaths from errors made, as you explained, or the number of deaths in the specified industry relative to the number of encounters? Because if it's the latter, the implication of the graph may not be that an industry is hazardous, but may simply reflect the critically ill nature of the population that the industry is serving. Did you get that, Leo?
I did. So the answer
Okay.
is the former. So the graph represents the number of preventable deaths for every
Mhm.
opportunity for an error. So it's not the total number of deaths. These are the number of preventable deaths.
Thank you. Any other questions from the live stream or from those logged in? I have a question, Leo. I'm curious about the last item you mentioned, which is about the way of the future, which is a digital quality system. What headway has been made in your experience, and how promising are the outcomes or the results of that kind of system?
So as I mentioned during the talk, there are some um, diagnosis or medical conditions where we are a bit more advanced in terms of what we know works, and we are closely monitoring this particular condition. So every hospital is graded in terms of how they respond to patients who are having a heart attack. Um,
The Innocence Foundation was born in 1980 to continue the enormous success you're sharing, supporting groups and individuals who seek excellence, creativity, and the drive to help their fellow
the advert
centering on the free program components of education, enterprise development.
I feel like I'm in North Korea. I'm someone else is advertising something while I'm saying something, which they're probably censoring. No, no, I'm just kidding. Um, so there are a few conditions where they are tracking the process itself, and they're tracking the outcomes. But it turns out that some of some of what we know are still changing over time. So a good example is sepsis. The most cited study ever now is the river study that was performed in the emergency room, where they had followed a protocol in terms of how to care for patients who are presenting with sepsis. And then 10 years after that protocol has been embraced, we have three new studies that now are saying that the protocol that was used in the river study did not produce any mortality benefit when they re-evaluated the protocol in much larger studies. And that really is the biggest challenge with quality, because quality depends on evidence-based medicine. And evidence-based medicine is not yet at a point where it's perfect. So we see all these pendulum swings in terms of what we think is the best care for patients. One decade, we think that steroids are beneficial for patients with sepsis. The following decade, we we get told that steroids don't impact the outcome. Um, and so if we can't really agree what works well, it's going to be difficult to measure quality. And the flaw that I had explained, the fundamental flaw is the fact that clinical guidelines are based on population studies. We are measuring average effect, and but in reality there's no average patient, and it really depends on the doctor of how he or she interprets what the study is supposed to be saying. And when when you leave that to the discretion of the doctor, you introduce a lot of variation in the way you interpret the literature. And that variation, as we know, is not good when it comes to quality. So I think the lack of understanding of what really works the best for every patient subset in a very specific clinical context is a big challenge to measuring quality. Uh, Everything is being uh, based on what we say as the art of medicine, when we know that there's no such thing as really, I mean, there is something about art of medicine, but there are things that you need to standardize. So one of the biggest problems is that if you have a patient present to 10 different doctors, you get 10 different suggestions in terms of how to manage that particular patient. And we know that that's not good quality because you have one patient being managed very differently. We know that there's only probably one best way to manage that patient. So, I mean, that's a long-winded explanation of what the challenges are to digitalizing the measurement of quality real time. But we're hoping that we're moving towards a better solution with the advent of precision medicine, which is just a rebranding of personalized medicine. But such a buzzword now, but it's not as easy as it sounds. Like um, we're nowhere close to precision medicine. We need the I can't hear you, Yella.
Sorry, now I am unmuted. I was going to remind you to share your webcam, but very good, you did it on your own. Thank you for your answer. I understand the limitations of applying as you know, just one standard for managing cases, and we realize the limitations of evidence, and that's where we see the other elements of quality like communication, a provider communication comes in, and how difficult it is to measure that dimension of quality, and all the more the measurement of teamwork and that so-called culture of quality. But I picked up a buzzword from you today, which is precision medicine, and that looks very interesting and promising as well. I'm going to read a question from NKTI from Dr. Ricky Quintos. You may know him. Can I read the question? I can't find it. His question is, you mentioned that anesthesia is considered safest among the specialties. Would you have a rundown ranking of which specialties are safest to the most unsafe?
Ooh.
Noting that he is a surgeon.
uh, I think the unsafest are the ones that require the most teamwork, because a lot of the errors turn out to be secondary to poor communication and poor teamwork. So up there would be the ICU where I work at, emergency room, and the operating room. Um, I think those are the areas where teamwork is most crucial. And it's funny because doctors always feel like there is a strong teamwork in their teams. Like when you have surveys, the doctors always say, "Oh, we have good teamwork. We all get along." The nurses don't feel threatened when they feel like they should report something. And then you interview the nurses, and you don't get the same response from the nurses. they still feel threatened. They still feel that they're not empowered to say something when they feel that there is some threat to safety. But there's no, I don't think that they've actually performed the comparison of the different specialties, but I think my guess would be the areas where you need the people to be really working well together are the areas where there are so much opportunities for errors. And OBGYN is the other area too, where it could be catastrophic if you don't have good teamwork of the different teams involved.
Thank you, Leo. Ricky, I hope that answers your question. So it's more of setting rather than specialty. Although you did mention anesthesia as a specialty. I don't know. I don't know why I cannot. There is another question online, Leo. This is from Catherine Gatdula. Um, what? No, no, it's not a question. Actually, she's requesting to view the video again, the video of your lecture, Leo. And the answer to that is yes. No, we are recording this webinar, and it will be available for viewing um, after this session. Okay, Ronald Ferrer is, that's for her. Stephanie Season, I may know her, Steph. Are there ways, has a question. Are there ways to measure the effect of specific interventions on quality, such as 12-hour shifts instead of 24 hours, or the changing of team members?
So quality improvement research is a very challenging area. Doing the before-after historical controls, those are laden with potential confounding most of the time. It's very difficult to really evaluate objectively the impact of an intervention, especially since most of the time there is some education that happens around a certain intervention, and you can't really differentiate whether the improvement in outcomes resulted from the intervention itself, or maybe it's because of the education that happened, or maybe because the people are aware that their performance is being measured, that suddenly their teamwork improves during the study period. But these are all the challenges of the domain of measuring quality improvement. And the other question, Yella, can you, the second part, I forgot what the other question is.
She only had one question, but there is another one now from Ruby Kaikobel. Do you think that the use of electronic medical records has improved the quality of care or improved tracking the quality of medical care?
So yes, but not the entire electronic health records. I also think that it might be contributing to some, what do you call this, un, un, something that we did unpredictable consequences. I think the part of the electronic health records that significantly improve outcomes, at least in the developed world, is computerized provider order entry. And that is something that everyone should really push for across countries. And you can't say that there's limited resources for, and we cannot afford a provider order entry, because I think if you look at the different components of electronic health records, POE has contributed the most in terms of avoiding errors from wrong dose or wrong medication or drug-drug interaction. So the short answer is yes. I really think that electronic health records have reduced the number of complications from medications.
So your answer is it has improved the quality of care.
Yes, it has improved
aside from
outcomes.
aside from all right. Thank you.
So yeah,
I
you
have
have to use Otago in a sentence.
Okay, here's another question. I am ignoring what you said. The question is, the effort to practice evidence-based medicine and following recommendations from guidelines that are put out by the various medical associations are frequently limited by the quality of the clinical trials available, which you mentioned in your talk. Unless the quality of clinical research improves, will the guidelines ever be truly clinically meaningful? And what can we do in the meantime to improve our own personal capability to provide quality care?
So I could spend hours answering that question. So my research entails secondary analysis of electronic health records. I consider electronic health records as lab notebooks because every day we experiment. Every day we don't know the best answer for the patient you're
Mhm.
caring for. We don't really know the optimal amount of fluids to give in the ICU. We don't really know whether drug A versus drug B versus drug C is the best for this specific patient. So every day we experiment, but we don't try to get lessons learned from those experiments. Most of the time, we actually don't know what happened to the patient 30 days from now, or whether this treatment that we uh, we provided is really the best one for that patient. So I'm a big advocate of what we term as secondary analysis of electronic health records. And I think this is very important in low and middle income countries. So the clinical guidelines in low and middle income countries are currently based on studies that were performed in the developed world. And
Yeah.
I don't think that we could believe that what's best for the Europeans and the United States are also going to be the best for the Filipinos or some other country. And we need to get people in low and middle income countries really enthusiastic about creating their own evidence, doing their own research, finding out what works best for the populations that they serve. And to me, the value of converting into electronic health records is not just to facilitate better care, but the bigger value is the digital data that you collect. And you could
Mhm.
perform analytics so you could figure out whether among Filipinos in a certain province, whether drug A is better than drug B by looking at what happened to those who got those particular drugs. Again, easier said than done. Observational studies are typically challenged by what we term as residual confounding, that there could be other reasons apart from the interventions that led to the outcomes and not really the interventions itself. So the type of analytics it's not easy. And that's what we're trying to do at the same time as we advocate for electronic health records. We're also trying to get more people involved with data analytics. So
You
um,
want to read?
a shameless plug, we're going to start a course on secondary analysis of electronic health records at MIT. It's going to be streamed globally without cost. And the reason for this is we want to get more people involved with knowledge generation, with evidence creation, and we want that to be based on your actual experience as documented in your own electronic health records.
All right. Thank you, Leo. So it looks like electronic medical records is the right direction, maybe baby steps, but in the right direction. And certainly not a shameless plug, Leo. We'll be interested to know how to sign up, when the course will start, etc., especially since you mentioned that it is at no cost. It's 12:57 in Manila, and so we have time for the last two questions. First is that quality is very difficult to quantify. Is patient safety and patient survival the only main objective parameters for um, quantifying or measuring quality?
So there are lots of discussion of whether mortality or survival, whether that is a good measure of quality, and there are more and more proponents of saying that that should not be the uh, the metric for measuring quality. Uh, but right now, mortality is the easiest to measure. Um, there's really only
Mhm.
two possible answers there, whether they're alive or dead. That's why it's become a very easy target for measuring quality in terms of health outcomes. But again, everyone is going to be interested more in the quality of life, and other metrics apart from patient survival or death. Patient safety is a bit easier, so that really pertains to not operating on the wrong leg, not operating on the wrong side of the brain. That's the reason why we do the timeout. That's the reason behind the surgical checklist. Uh, I think patient safety is a little bit easier to measure, but patient safety does not mean quality. Not just because you're safe doesn't mean that we've achieved the best outcome for you. To me, patient safety is the first step. It's the minimum requirement. First, do no harm. We should not be harming you, but that's really far away from what we would like, which is the best possible outcome given the condition that you have.
Thank you, Leo. And the last question um, is, in a third world country like the Philippines, how can we improve the quality of care in the absence of electronic medical records?
So I think the first step, and this is based on experience. So my other research project involves global health informatics, which is designing information systems for digital capture of health data in low and middle income countries. And we go in there and we try to introduce all this technology, the use of mobile health applications, and then most of the time there will be a successful pilot study, but when it comes to scale up, we almost always fail, and we realize that our problem is that there is no
Mhm.
culture of quality improvement. People don't really appreciate or understand what we're trying to do. There's the novelty of the technology, but there is still no accountability. There's still no interest in continuous
Yeah,
learning and in continuous um, attempts to improve the way you deliver care. They don't want to be measured. They
improvement.
always think that electronic health records or measurement of quality is a way for us to see how poorly they're performing. So there's no interest in constantly trying to improve your care. To me is the first step. Not everyone there has to be that culture of patient safety and quality improvement. Everyone has to feel that they are accountable, that to be constantly contributing to looking at the system as a whole and improving the effectiveness and the efficiency of that system. So we have to do that before we could even think of electronic health records.
So, a system of accountability, a system and a culture of accountability for each patient outcome, each patient encounter.
Yes.
Okay, that was the last question. Thank you very much, Leo. That was a very stimulating lecture and a very interesting discussion. And thank you to all our participants in this webinar who are either logged in or are viewing this lecture from the live stream. As of 12:46, we had 49 people viewing our webinar via live stream. And we have 1 hour through us the definition of quality of care, and there is no agreed upon definition. I learned many things like that errors in healthcare are more common than we thought, and a lot of it is attributed to the organization and design of the healthcare system, and in particular, very top-down hierarchical system. It does not quality improvement is possible in all settings, and even in a low income or low resource countries or settings. It's actually not an excuse not to pursue quality improvement, but actually an impetus to pursue quality. Shared with us some landmark studies on defining quality, measuring quality, and safety. And lastly, he shared with us the elements of quality of care, which can be grouped into three main elements, which are the application of evidence-based medicine in decision making, in clinical decision making, but this has its limitations. Communication, patient-provider communication and compassion, and shared decision making between patient and provider, and the last dimension being teamwork and a culture of quality. Thank you very much, Leo.